All right. Hi, everyone. Just making sure this is being recorded. It is. Okay. So welcome to AHDAM's Webinar Wednesday. Today, we're going to talk about best practices for the appeals process. I'm Denise Wilson. I'm your host and one of your presenters today. And this webinar, as many of our webinars, are based on requests that you all have sent in and based on questions that you all send in to us about different processes for best managing your appeals. So hopefully this will answer some of your questions. You can listen via your computer audio or dial in. So I've got the dial in numbers for you all there. And let's go ahead and get started. We should have time for questions at the end. Here we go. So if you're new to GoToWebinar, you should have a little attendee participation box that pops up on your screen. You can minimize or maximize it using this little arrow, red arrow right here. So I think it auto hides on you sometimes. So just use that little red arrow to pop it open again if you need to. You can download the handouts from the handouts drop down, and you can enter your questions under the questions panel. So as we go along, if you have questions for us regarding the content, go ahead and enter them there. If you're having technical problems, you can enter your problems into that area as well. We have Alice with us today, who is monitoring and will help answer any questions that you're having if you're having technical difficulties. Okay, CEUs, contact hours, we do offer those only if you are an AHDAM member and only if you attend this live webinar. So if you're watching this as a recording, we do not offer CEUs for that. So to get your CEUs, you have to be on this webinar for at least 15 minutes. So make sure you stay on all the way to the end because we do check that. And then there's a survey that will pop up automatically at the end of the webinar, and you need to complete that survey. And it just takes a couple minutes to complete it. You do have to complete that in order to get your CEUs. We email the CEU certificates out to you, usually within about a week, because we do go back and double check, all of these criteria before we send you the CEUs. And a disclosure that there are no individuals in a position to control content for this activity that have any relevant financial relationships to declare. When the survey does pop up for you, you will be prompted to select the CEUs that you're interested in, and you can select as many as you want. So there's ACTIS for CCDS, there's NARI, CCMC for case managers, HEMA, and ANCC for our nurses. Okay, our next complimentary webinar will be Wednesday, October 26th at 2 p.m. And we're going to be talking about total joint surgery denials and appeals. And our AHDAM Advisory Board member, Deanna Fling, she's been writing appeals about as long as I have and doing a lot in the outpatient realm. She's going to be presenting, she's going to be our guest presenter for that one. You can register for that now by going to the AHDAM homepage. And then just a reminder, there are some joint webinars coming up. One is tomorrow at 1 p.m. about sepsis. So this is a joint webinar between PayerWatch and the association. It is free tomorrow and next Wednesday. It's different topics. I mean, they're both going to cover sepsis, but different aspects of sepsis denials and appeals. So it's not the same workshop on Wednesday as what we're presenting tomorrow. You can sign up on for those by going to PayerWatch.com, and you can register for those. Free to attend, but no CEUs for those two workshops. A little bit about us. We are the nation's only association dedicated to healthcare denial and appeal management. We are here to support you who are working in this field by providing you education, support, references, resources, whatever you need to get the job done. And our vision really is to help create an even playing field so that who are working in denial and appeal management are working by the same rules and guidelines that our payers are working under. So if we can better understand, payer behaviors, we can be better at making sure that our providers are being paid appropriately for services that they provide. So Denise Wilson is me, and I'm President AHDAM and Senior Vice President at PayerWatch. I've been in healthcare for well over 30 years now, and been doing denials and appeals for about 17 years. Done hundreds of ALJ hearings, and I do lots of education on denial and appeal management. So also, if you are part of an association or an organization, like if you have a local chapter of AHDAM or ACDIS or NARI or whatever, or any other, a large hospital system, and you'd like to have me present education for your teams, just let me know. That's kind of what I do these days. Our other presenter, Kendall, I have you down as host as well. Host and our other presenter, Dr. Kendall Smith, who's Chief Physician Advisor at PayerWatch. Dr. Smith is a Senior Fellow in Hospital Medicine, currently acts as Chief Physician Advisor for PayerWatch and AppealMasters, and he's also a leading appeal educator and appeal services. I said this the other day when I was reading your bio. PayerWatch is a leading appeal educator and appeal services firm for hospitals and health systems, but Dr. Kendall Smith is also a leading appeal educator. He's been deeply involved in denial and appeals management throughout his hospital career. He served as a physician leader on hospital revenue cycle management teams, serving as physician advisor for clinical resource management, and he is an AHDAM, ICD, CM, PCS approved trainer, ambassador. I do have to read this disclaimer. The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of our members. We do not certify the accuracy or authority of these materials. The materials are distributed and presented as research information to be used by AHDAM members and attendees in our webinars in conjunction with other research deemed necessary in the exercise of your best independent professional judgment. AHDAM claims no liability in relation to reliance on the content of these materials. The views expressed are the views of the materials authors, do not necessarily represent the views of AHDAM. Any references are provided for informational purposes only, do not constitute endorsement of any sources. So it's really important today, I think, during this particular webinar, because I'm going to be talking a little bit about rules, regulations, and a little bit of legal stuff. And I'm not a lawyer. Dr. Smith is not a lawyer. So I just want to make very clear that these are our recommendations for best practices, but we are not representing in any way any kind of legal advice. So our learning objectives today is at the conclusion of the webinar, you'll be able to prepare an appeal letter with an argument appropriate for the level of appeal. And at the conclusion of the webinar on the survey, you're going to see questions on these three topics: the ability to identify an appropriate appeal argument structure for an administrative hearing, the ability to identify two informational elements crucial to preparation for a peer-to-peer discussion, and the ability to identify one circumstance when a lower level appeal letter requires a revision before filing at the next level of appeal. Okay, now that we have all of the housekeeping stuff out of the way, I'm going to turn it over to Dr. Kendall Smith, and he's going to talk to us a little bit about peer-to-peer.
Sure. So one of the great things I like about peer-to-peers is it's an opportunity to prevent a lot of downstream work. If done successfully, this can lead to a quick overturn. My personal experience with peer-to-peers is it's so much easier to get a conversation out of 2 dimensions off a piece of paper and into a 3-dimensional process where you actually have someone who's on the other end of the phone. We can only hope that they're listening to what's being said. That said, the most key portion of any peer-to-peer is preparation. You don't want to go into these things and try to wing them. You need to set up your case, collect your evidence, understand what's being disputed. understand what the insurance contract provides for, and get all of your ducks in a row. So over the next 2 slides, I've got a list of steps that I view is crucial to completing a successful peer-to-peer. Ideally, you'll have notice of an adverse determination letter or something from your UR nurses. Perhaps a fax came over through UR that said, the initial screening did not support inpatient level of care. Attached to that may be an MCG guideline or intraqual, and a statement that the patient failed interqual or MCG, if you're lucky. So take a look initially at what information the physician advisor or nurse on the other end of the phone has in front of them. I think too often we assume that they have the entire chart at their disposal. Quite often I found that that's not the fact. They may have a few pieces of paper from the emergency department. They may have history and physical may not be completed for 24 or 48 hours after the patient's in the hospital. You may now have that. The person that you're conducting the peer-to-peer may not have that. And there's a lot of critical and crucial information that can reside in that document. It's important, if this is a contracted provider, to take a glance at the coverage guidelines for the particular service that's being requested. The payer manuals are state specific, and you can, if your managed care department does not have them available to you, we always recommend that they're downloaded and kept on a local drive so that folks in UR and denials are able to access them, and or at least portions of them, to understand what's covered, what's not covered, what sort of evidence the payer takes into account in making a determination of medical necessity. You can always go out on Google and put in the payer name, the state, and the plan type, and the words payer manual, and 9 times out of 10 you'll find it. And in that you'll find language as to what constitutes medical necessity, that definition. So familiarize yourself with the payer-specific wording as to medical necessity for whatever you're going to discuss. It varies from payer to payer. Some payers even have diagnosis-specific guidelines. They may define, say, for example, we'll only cover sepsis according to SEP 3 criteria, and that may be set forth in those guidelines. Next slide, Denise. As I said, this whole thing will take you about 15 to 30 minutes. Some of these you can do very quickly if it's a really egregious denial. For example, if the patient came in and ended up intubated on pressors in the ICU, and the argument is that there was no need for inpatient care, those sorts of things you can manage with the ER notes, or even off the cuff if you're forced into it. The things that you want to take into consideration and have at your fingertips, maybe jot something down on a legal pad, are clinical exam notes, any relevant abnormal vitals, and imaging results. I stay away from things that are mildly abnormal. We're looking for evidence of, like one might with a SOFA score, you're looking for evidence of major organ involvement if you're going to be talking about inpatient medical necessity. So things like encephalopathy, documentation that the patient's confused, acute kidney injury, you want to make sure that you have a known or suspected baseline creatinine and a current creatinine available. Liver disease, you'd want to show altered ASTs, ALTs, transaminases, etc. And then what's been done up to this point. I think too often we kind of fall short on this point, because there's a lot of work that physicians tend to order that we don't necessarily consider to be contributing to inpatient care. For example, a patient coming with seizures who's put on a one-to-one nursing for a neuromonitoring, or a patient with an acute CVA who needs one-to-one nursing. That's not a level of care that one would expect in observation, and that needs to be voiced to the physician advisor, medical director, or the person on the other end of the phone to communicate why inpatient care in that case was medically necessary. And one of the biggest things that I think we're proponents of and have been successful with are the use of evidence-based guidelines for that patient's particular illness. You have to remember that MILIM, interqual, other guidelines are distillations. They're distilled down from peer-reviewed articles, and they kind of make a stew out of all of them. AppealMasters, PayerWatch, we actually go back and look at the original evidence-based guidelines, and quite often you'll find that the patient that you have was never meant to be included in that particular guideline. You may have an elderly 85-year-old African-American woman with diabetes and hypertension who's coming in with unstable angina. An article that says unstable angina can be dealt with, in the ER, an observation unit with minimal risk. And then you look at the patients studied and you realize that there were no patients of this demographic included in that study. So it's your chance to present your case, but to present it with some intelligent backup, but also to point to the limitations of interqual MCG, even things like SOFA scores, which were never intended for diagnostic purposes. Those are intended for statistical purposes. So take-home messages are: be prepared, know your patient, know your payer, know your evidence, have it all at your fingertips. And one of the things that I've often found challenging is to be patient, I think would be the fifth P there. It's very easy to get frustrated at times when you feel that the other side's just not listening or budging. But remember, you'll always have a chance with a written denial letter and a written appeal to further make your case. And that's where Denise is going to take this, assuming that we haven't been successful in the peer-to-peer process. So Denise, I will turn it over to you and your expert tutelage.
Thanks. Okay, so one of the things that I talk about a lot and that people ask me about is, first of all, being efficient through the appeals process, because we're spending money to try to retain money or get money back, into the revenue cycle. So we have to make sure that we're working smartly and efficiently through the appeals process, as well as being effective. So the first line I have an example of what I believe to be best practice is when a denial is issued and you appeal that denial at the first level, and then the decision comes back that they've upheld that denial and they have the same denial rationale that they used the first time around. Put the new address on it if it needs to go to a different address for a second level of appeal. Put a new date on it, send the same appeal back for the second level if you're sending it back internally meaning back to the payer who initially denied it. Now, I'm going to talk about that a little bit more in the upcoming slide. So the whole idea is you're trying to move that appeal through the internal appeal process. And when I say internal appeal process, that means process that is set up with the payer, and get to external review. So external review could be for traditional Medicare. We consider external review to be when you get to the administrative law judge level, even though the second level of appeal, which goes to the qualified independent contractor, and that has the word independent in it. And so you would think external review starts there. I really consider external review for traditional Medicare to start at third level, which is the administrative law judge. I feel like they really are the ones who are independent of the payer. If it's a commercial payer, managed Medicare, external review, we could be talking about going to an independent review agency, mediation or arbitration, and you have other resources as well for external review for your commercial payers. So the second line, I have what we're normally used to is you get a denial is issued, you file your appeal at the first level. If they come back with a different denial rationale, and then of course you're going to rewrite your appeal letter before you send it back for your second level review, because you're going to then rebut, refute, argue against whatever the different denial rationale is. So we see that a lot we'll see coding cases come back with a clinical validation denial rationale or clinical validation, and then they'll come back and say, okay, we'll let you have that diagnosis, but we don't like this other one. We don't think you coded it correctly. Okay, your sepsis is clinically valid, but this diagnosis is not. So we see that quite a bit, and of course at that point you do have to rewrite your appeal. And someone had in the community had been talking recently about how often can the payer change the denial rationale, and my response to that would be however many times you can appeal. So I'm not aware of anything that says a payer cannot change their reason for the denial rationale from level to level to level, except CMS did squash it a bit with the RACs. When the RACs were doing that pretty heavily a few years ago, they did kind of put their foot down. But as far as commercial payers, they pretty much, however many levels of appeal is how many times they can change their denial rationale. Kendall, you're muted. I think Kendall was wanting to say something, but you were muted. Okay, what about in this case where on the first line, where they come back with the same denial rationale and you just put a new address and a new date on it and send it back to them? I know you guys have seen this because y'all have let me know that this is happening to you. We've seen it as well. The payer might refuse your second level of appeal because they're saying, well, it's the same argument you said at the first level. And they'll say that's not a valid appeal. And I would say, well, where in the rules, the laws, the regulations, the contract does it say that I have to submit new information when I appeal to the second level or third level or whatever? So here are I'm going to give you some arguments that you could use in your appeals to argue that back to the payer. So you could say per NCQA requirements, state regulations, contract terms with the payer, wherever you could pull the language from your hospital. So anywhere it's purple here or lavender, you would put in whatever is appropriate to that particular case. The hospital is entitled to a full and fair review by a different reviewer not involved in the initial determination. So a lot of times you're going to find that in your state regulations, and you can quote it from there. Now, NCQA, Kendall, I know, they don't always have, I don't know that hospitals always have insight into those regulations, right? Or is this one that might be open and available to hospitals, the one about full and fair review?
That should be available to most hospitals. The NCQA is a credentialing organization to insurance companies as Joint Commission is to hospitals. It's required to have their certification to participate in CMS programs, Medicare and Medicaid. So if you're running into an ongoing recurring problem with a particular payer, you feel there's evidence for not reading the denials, they're making incorrect decisions, etc. And then filing a complaint with NCQA that they're not completing a full and fair review is appropriate. My experience, my advice is to bundle at least 5, if not 10 similarly situated claims together. You got a much better chance of getting their interest, involvement, and attention than if you just send one over and say they didn't listen to us here. So you want a pattern. NCQA's website is ncqa.org, and there's information there on how to file a complaint. Sometimes it'll be hidden under how to report fraud, but there's contact information available through that resource.
Okay. So then you could go on to say the payer's refusal to accept our appeal as valid is in direct opposition to this entitled right, and the payer's action is equivalent to an attempt to deprive the provider of the opportunity to complete the internal appeals process in order to advance the case to external review. Because in my opinion, that's what they're doing, is they're saying, oh, that's not a valid appeal. Well, how do I get to external review if I don't exhaust the internal appeal process first? And if the payer's not allowing me to exhaust the internal appeal process, then they're essentially blocking us from getting to external review. So I don't think they have the right to do that. Now, one of the cases that I got involved in order to argue this is what I wrote at the very top of my level 2 appeal. When we had our follow-up team had called the payer and said, where's the status of our level 2 appeal? And the payer said, oh, we dismissed it because it was a duplicate of what you sent in the first time. So this is what I put in my letter. Sorry about that. Of note, the provider was advised on 4/2/2022 via phone conversation with ANJ that the level 2 appeal had been dismissed as a duplicate because no new or pertinent information was received. Dismissing the level 2 appeal as a duplicate deprives the provider of their right to fully avail themselves of the appeal process, and hospital requires payer to consider the level 2 appeal a valid appeal. And they did. When I sent this in, they did accept it as a valid appeal, and they upheld it. But that's has more to do, I believe, with the strength of the case than it did with the fact that they thought we were just that we shouldn't be sending in a duplicate appeal. I mean, they're going to rubber stamp and send us the same denial rationale at every level. There isn't anything new. We've written our strongest appeal at level 1. There isn't anything new to add. We're just trying to get through the process, being efficiently moving through the process so we can get to someone outside of the internal appeal process. Now, then I also asked our legal consultants to do a little investigation and kind of come up with some wording for cases going forward. And so this is what our legal team came up with. Again, I'm not a lawyer. Dr. Smith is not a lawyer. We're not giving you legal advice, but here is just some words for you to consider. Here, the appeal level, so you'd write in there level 2 or what reconsideration, whatever the payer is calling it, on the services for a patient was dismissed by the payer as a duplicate case with no new or pertinent information provided. However, there's no requirement in either the agreement between the payer and the hospital or the payer provider manual for subsequent provider appeals to include new information. In fact, the provider manual only states that providers may include additional information as part of the appeal. So may include additional information. But regardless of whether additional documentation is supplied, the payer is still obligated to provide a full and fair review of the appeal. Now, our legal team also supplied me with a reference to this particular state. This is actually in Georgia. Georgia's state regulations that talk about providing a full and fair review of the appeal to kind of, drive the point home.
Denise, timely, interesting popped up while you were talking about this with legal, with our legal department. We had, on behalf of one of our clients in Georgia, had a series of 200 cases that the appeal rights were not appropriately considered as they were out of network Medicare Advantage. We were able to find the name of the chief legal counsel for the insurance company in North America, sent them an email just with general information. In 5 minutes, had a response asking for the entire list. So, if you're not getting anywhere with lower mid levels of appeal and you've got a lot of money at risk, I think one of the earlier comments we talked about, and one of the things to consider here is you can always reach for the top. You may not get a response, but if you have enough cases, you're going to get in all likelihood, someone interested on the other side. So it's a question of persistence.
Absolutely.
But you don't want to do it one at a time. These things need to be batched up, and those contacts should be made with the knowledge and permission of your management staff.
For sure. So it really is, the appeal process, it's what we have. It's what's been developed, and that's our world. But there's a lot of times when we're not going to make headway. We're not going to, move our cases forward. We're not going to be successful for the revenue cycle if we don't start taking advantage of our opportunities to go outside of the appeals process to get some movement, and especially with commercial payers, managed care payers. Okay, so let's move on to another issue. So when you get in a denial, and the denial is issued with a lack of clarity of denial rationale, or no denial rationale is provided, and we see a lot of this at hospitals where, you might get an EOB that says reason code 50, not medically necessary, but you don't really know, but you don't get a denial correspondence that says, well, was the procedure that we did on the patient who was here for 7 days with an acute, belly that needed exploratory surgery, was the surgery not medically necessary? Was the admission not medically necessary? What are you denying? And they don't tell you. So you get a denial issued without denial rationale, or it's not clear. Is it coding? Is it clinical validation? Why are you objecting to a particular diagnosis? What's your beef with that diagnosis? So at first level, then you're going to write a best guess appeal based on your knowledge of what the payers are typically going after when they deny a claim that has sepsis on it. It's probably clinical validation. So you're going to do a best guess appeal, but you can also include a legal argument, and I'm going to show you that on the next slide. Then the denial gets upheld, and now they provide you the denial rationale. So we see this a lot where once an appeal is filed, you will get correspondence with denial rationale that maybe you didn't have at the first level. Then you rewrite your appeal to address that denial rationale and send it to the second level. So that's great as long as you have 2 levels of appeal. Now, I'm aware that some hospitals have contracts with payers where they only have 1 level of appeal, and then you're really, in trouble because you've used your 1 level of appeal to just do a best guess on what was being denied.
And a lot of times, you want to comment real quickly on the nuances of just responding to an innocuous reply for a medical record from a payer with 1 level of appeal?
What's that?
I said, do you want to comment on in some cases how we've seen the innocuous response to a request from a payer, an insurer for a medical record in certain hospitals with 1 level of appeal being counted as an appeal, and how to avoid that happening?
Right. Yes, we have seen that happen as well, where the payer has requested the medical record in order to determine whether or not they're going to pay a particular claim. So it's not necessarily an audit, but just they have a claim. We need to look at the medical record before we pay this. You send the medical record in, and they take that as a level of appeal. They say, "Oh, you've appealed this." Well, no, because we're just sending the medical record in for your request, so you can pay it. So this is a legal argument that our legal team put together for us. This is an example from, I just picked Illinois, the state I live in. So every state's going to have regulations on the books. You can go to your state's Department of Insurance, and sometimes they're called something other than the Department of Insurance, and find the regulation that applies to your particular state. So in this case, the payer failed to provide a reasonable, accurate explanation for why services provided were denied. According to Illinois Administrative Code, and we have it cited there, they must, when denying or underpaying a claim, provide a reasonable written explanation of the basis of the underpayment or denial. And it shall clearly set forth the policy definition, the limitation, exclusion, or condition on which the denial or underpayment was based. And then you can fill in what was lacking in the correspondence that you received. And then you could go on to say that their denial letter violates the law by not including that information. Retrospective authorization is appropriate when the payer's letter of denial does not conform to the notice requirements set forth in Illinois law. Now, when you see those words, retrospective authorization, you're thinking, oh, you mean authorization for inpatient admission. That's what I think, being, having a nursing background and being, those are the types of appeals that I do most often. But what they mean by retrospective authorization just means it should have been paid. Okay, so whether it's an outpatient claim or, services or physician, physician's office or whatever, just means that your claim should have been paid appropriately because their denial letter didn't conform with NOS requirements as set forth by law. Okay, let's go on to another issue that I get questioned about a lot, and we talk about a lot in the community, and that's the payer's use of screening criteria. So I have a couple of different examples. One is when the payer uses screening criteria, and it is and they've denied your inpatient admission. So this is where we're talking about inpatient here. So they use interqual or MCG. Those are the two main screening criteria we see hospitals use. Denied it, but according to standards of care, according to how sick the patient was, according to your physician who treated the patient, according to the physician advisor who looked at the case, everything points to the patient should have been admitted as an inpatient. So here's a little argument you can use to kind of push back on the payer's use of very strictly following interqual or MCG. You could talk about how that's it's merely an objective tool to help guide physician decision making. The criteria does not consider, and this is kind of our biggest beef. I know Dr. Smith talks about this a lot. The criteria does not consider specific comorbid conditions that place a patient at a greater risk of adverse outcome. So the MCG criteria, they select one, and the patient has 2 or 3 or 4 comorbid conditions that support that the patient needs to be admitted, but the payer says, well, it doesn't meet this one criteria very strictly.
And if you go into Millman, for example, there's actually a preamble, or there used to be, that said, this is not used to supplant, or layperson's terms, second guess physician judgment. And it represents an idealized plan of care for an idealized patient with idealized follow-up, whatever idealized or ideal means. But for most hospitals and patients coming in through the emergency room, I think the word ideal anything is a stretch. So they're talking about the perfect patient with great follow-up, a great support and social network, and cut and dry as to what's going on. So what you really want to focus on are the limitations of these guidelines, and the fact that they're not all encompassing. They were never meant to be. I mean, CMS has said as much. So, stress their weaknesses and make your case.
Right. So, yeah. So, the attending physician has to look at the entire presentation, their acute and chronic comorbidities, and interqual MCG is just one tool that helps them in that decision making. It's not there to replace the physician's professional training and expertise. Okay. What about their misuse of screening criteria? So then let's say they're using screening criteria and you use the same screening criteria or even a different screening criteria, but they use an incorrect one or they misapplied it. Then you can argue back to say that although it's ultimately the provider's decision to admit the patient as an inpatient based on their professional judgment, interqual or MCG's established means assist the provider in making that decision, and your hospital employs interqual or MCG's a screening tool to review the patient's need for inpatient status based on your established review process that your hospital set forth by your hospital. That patient met medical necessity criteria for inpatient status. So if you're using MCG or interqual and they did meet based on your review, and then the payer says they don't meet, then that's something you can argue back to the payer to say, well, yes, in fact, they do meet, and they do meet for this reason. Now, it was interesting. We did a webinar, I don't know, a few months ago, I think, talking about the use of how you argue against payers who use MCG or interqual. So when you are faced with a denial based on screening criteria, and those screening criteria were misapplied, okay? So they were misapplied. Do you argue back that, hey, you misapplied the criteria, you didn't consider this was going on with the patient or that was going on, or you used the wrong criteria? Do you just argue that back, that that screening criteria was misapplied? Do you not address the screening criteria at all, and you just argue standards of care, support inpatient admission, evidence-based guidelines, or do you do a little of both? And these were the results we got when we did this poll during the webinar. So 5% will just argue back simply that you misapplied the screening criteria. 22% argue strictly by evidence-based guidelines, and 70% do a little of both. So there's been some discussion in the community about what's right and what's wrong, or how people feel about this, I guess, because I don't think there is a strict right or a strict wrong. Some people feel that if you just argue the screening criteria were misapplied, then you're agreeing that it's okay to use screening criteria to determine inpatient medical necessity. They feel like you're agreeing with the payer. The better method is, they will argue that the better method is to support the inpatient admission based on standards of care. And I've always been a big proponent of, it all comes down to standards of care and evidence-based criteria. But if you have a payer that if you just go back to them and say your screening criteria was misapplied, or you didn't consider this, or you didn't see this in the record that would support your screening criteria, and that payer will overturn it based on that, why wouldn't you go for that? Because that's going to be more efficient than creating an argument around why that patient was sick enough that they required inpatient admission. So I'm kind of, and I know from folks that I've talked to that does happen, that they do have success with just going back and saying, well, your screening criteria are misapplied. So I guess I'm not going to say I'm on one side of the fence or the other. I'm probably more on the side of we need to use standards of care to support inpatient admission. I mean, I'm definitely on that side. But thinking about the efficiency of getting the work done, if I can do a 3 or 4 sentence argument saying here's where your screening criteria are misapplied and get it overturned, that's kind of interesting. So I'll just leave it at that. Okay, what if the payer misrepresents the documentation? If the payer makes erroneous statements in the denial, they say the patient is afebrile, and in fact, the patient is presenting temperature of 101. Definitely, you want to refute every erroneous statement with facts from the documentation, and that's kind of like one of the first things that we do in our appeal is we will pull out and point out mistakes that the payer has made in giving their denial rationale. And one of the reasons that we do that is it sets the argument early that the payer is not conducting a fair and honest review of the case. If they're stating things that are not true or not found in the record or are found in the record and they said weren't there, that's helping set that argument so that if you do ever go to arbitration, mediation, external review, administrative law judge, or whatever, you said early on, look, the payer, or when you go to your joint operating meetings or your contracting goes back to the payer, you have evidence in these appeal letters early on in the process that you have pointed out you're not getting a fair deal. Okay, so definitely that's something that you want to do. Okay, let's talk about traditional Medicare I think I just have one slide on this. How you prepare your appeal for a level 3 administrative law judge hearing. We do write our appeals a little bit differently when we go to the administrative law judge than what we may have written at level 1 or level 2. So we will look at our appeal letters another time and do a little bit of rewrite on them, because we need to help educate the administrative law judges on what's going on with the patient because they do not have a clinical background. So explaining the medical necessity in simpler terms, and I kind of want to say that doesn't always just apply to the administrative law judge. I almost feel like we have to do that for commercial payers too, because we don't know who's looking at them on the other side, if they always understand what we're saying medically. But definitely for the administrative law judge, you want to make sure that you are talking in a little bit simpler terms for them. Connecting the dots between what's in the medical record and the payer's policy. So the ALJ can see very clearly that per the payer policy, it should have been paid. So when we're talking about things like local coverage determinations, national coverage determinations, which a lot of times have to do with outpatient claims, outpatient services, outpatient care. We want to make sure that we're very clear in saying this is what Medicare says is covered, and all of our documentation supports that. Explaining to the administrative law judge how the payer maybe didn't consider standards of care, they didn't consider coding guidelines, they didn't consider widely accepted diagnosis validation methods, or maybe this patient had some extenuating circumstances and the payer did not consider that, even though, you know, we talked about it in our appeals. Same for if you're going to mediation, arbitration, external review agencies. Include statements that refute the payer's behaviors early in the appeals process. So you've already established that there's a pattern from this payer of not doing fair reviews, if that's a pattern for that particular payer. And then the other things are kind of the same as if you're going to administrative law judge, connecting the dots between the medical record and the payer policy, and explaining if the payer didn't consider the gold standards of what we consider when we're supporting documentation for payment of claims. Okay, clinical payment policies, these primarily relate to outpatient services or procedures. So our commercial payers will have what they call clinical guidelines or clinical policies or clinical payment policies. And then on the traditional Medicare side, we have our local coverage determinations and our national coverage determinations. The policies are going to be payer specific. So Aetna's policy to cover total knee is going to might be somewhat different than United Healthcare, somewhat different than Blue Cross and Blue Shield. They can all write their own policies. Even for traditional Medicare, the local coverage determinations are written by your Medicare administrative contractors or your MAC. And those can actually vary from MAC to MAC to MAC. They're usually pretty similar, but they can vary. So you have to pay attention to that. So consider creating a checklist of the required documentation or diagnosis codes that payer has said they will cover if that's documented in the record. You can use that checklist as an educational purpose for providers who are the providers doing the total knees or the HBO therapy or whatever it is. You can incorporate that checklist into an appeal letter template. So create a template for those outpatient claims that you're appealing all the time. Put a checklist in there of what all needs to be in that record in order to successfully overturn a denial. That way it's very easy then. You don't have to go look for the LCD or the clinical policy bulletin. You've got it in your template. You can very easily compare that to what's in the medical record and kind of guide how you're going to structure your appeal. Explain any outliers. So if the patient doesn't tick off all the boxes in the payer-specific policies, explain why not. So for example, as a long-distance truck driver, Mr. Jones was unable to complete a course of physical therapy prior to his total knee replacement surgery. Okay, you can't just stop in any town and say, hey, I need my physical therapy. But he did practice strength training exercises while on the road as prescribed by his physician. So not every patient's going to have extenuating circumstances, but some will, so make sure you're explaining those. Okay, so this is just an example of here's an NCD, a national coverage determination. This is traditional Medicare for hyperbaric oxygen therapy. So they state in their NCD, reimbursement for HBO therapy will be limited to that which is administered in chamber and is limited to the following conditions. And they've got a list of about 15 conditions. But again, you can put this in your appeal letter template. Then just keep the one that applies to your patient and delete the rest of them out of there. So this patient had gas gangrene. Okay, well, that is covered by the NCD, and here's where it is in the medical record. So we met that particular criteria. They also go on to say the use of the HBO therapy is covered as adjunctive therapy only after, and this is for specifically for, they're talking about diabetics, only after there are no measurable signs of healing for at least 30 days of treatment with standard wound therapy. And then they go on to describe the standard wound care in patients and what does that mean. And there's a whole list of things here. They have to assess the patient's vascular status, correct any vascular problems in the affected limb, optimize nutritional status, and on and on and on. So put that in a checklist and say, do we have all of this? Did all of this occur? And then you're left with, where is that documentation? And my little purple arrow got off base there. It's kind of up in the paragraph instead of in my sentence, but where do you find that documentation? Is it in the wound center? Is it at the physician's office? Is it in home care? Okay, you've got to track that stuff down so that you can include that with your appeal. So let me go back to say one more thing about that before we wrap it up. So you've got to be able to have good processes in place to be able to get this documentation that you need quickly and efficiently from those different agencies or those different providers, as well as providing the wound center, the physician's office, the home care, what the requirements are for providers to get paid for those services. Okay, so they're coming in for HBO therapy. I need to know that there's documentation that all of this has been completed so that our hospital can get paid for providing that HBO therapy to your patient that you're referring to it. Okay, so some takeaway points and then we'll get into some questions. So think about your appeal work being efficient as well as effective. Don't be afraid to stand up for your rights, your legal and regulatory arguments. As I said, we really have to start taking advantage of the avenues to go outside of the traditional appeals process. Be thoughtful in your arguments for or against screening criteria. Just going to leave you with some thoughts about how you want to manage that. Educate your ALJs and other non-clinical adjudicators when you're going to external review. And don't be a stranger to your clinical policy bulletins. Make sure that you have access to them, that you are referring to them in your appeal letters if your care is covered by clinical policy bulletin, and make friends with the keepers of that documentation so that you can get it. They know what you're asking for when you ask for it, and you can get it quickly to help support your appeal. Okay, I just want to, before we get into Q&A, say thank you to our support team at the corporate office. They're a bunch of cuties, aren't they? I just love them. Okay, I'm going to pop over and see what questions we might have that we can answer for you. So give me just a minute to open those up. Make them big enough for me to see. Okay, here we go. And if we don't answer your question, we do the best we can to post a little Q&A. It usually takes us a couple of weeks to get that posted on our website. The recording is usually up within a few days, a day or two. But the answers takes us a little bit longer sometimes. Okay, somebody asked Dr. Kendall if you were talking about medical necessity peer-to-peer or DRG peer-to-peer, and I think you were talking about a little of both when you're talking about doing peer-to-peer.
Yeah,
you're talking about sepsis.
It can be anything. I mean, peer-to-peer really is a chance to resolve a disagreement and not get into a back and forth on paper. So it can it's really just a difference of opinion as to the provider believing that a service should be covered, be it inpatient, be it the medical necessity for doing a total knee, where Denise mentioned the case of the trucker who couldn't complete a course of physical therapy, but where you want to have that discussion with another physician. And the reason being is that it's just much easier to get into the nuances of a case that you may forget to commit to paper and get somebody on the other end to understand. You get a really quick, it's instantly gratifying or instantly frustrating because you'll get an instant feeling that they understand what you're saying, what your argument is, or sometimes in the alternative, they dig their heels in and disagree more. But it can be used to resolve any type of payment dispute.
Okay. How would you handle a payer whose medical director states his hands are tied because the patient does not meet the screening tool criteria, interqual or MCG? I think we heard that from Dr. Osman during the sepsis. I think, didn't he touch on that during the sepsis?
Yeah, you have to get into, this is where I'll start looking in the chart for colorful language. And, you first have to get the director to realize or agree that those criteria are not the be all to end all. They're not meant to usurp physician judgment. And if you've got a clinician that's good with documentation, we talked about an instance of a patient having SIRS criteria where the doctor wrote non-toxic versus the ER clinician documenting patient is ill-appearing or toxic. And go diving into the chart looking for those kind of colorful adjectives that can help to support your argument that Milliman really can't account for. Things like confused, things that may not necessarily be codable but aren't normal expectations, and to bring those forward. But first and foremost, you've got to get an agreement with the person on the other end of the phone that MCG or interqual are guidelines, and they are not meant to second guess physician judgment.
Was that it? You kind of left it with
Yeah, is my period when I'm still thinking, but let's stop at that point.
Okay. Here's one. I don't know, because we've been talking to some of our some providers on the in California recently. So I don't know. I'm going to throw this out here, Kendall. I don't know if we have an answer to it or not. We can always try to answer it later if not. But what do we do if the insurance company never exhausts their internal appeal options and we can't get to that next level? For example, California Health and Wellness has unlimited appeal tries, but there is never language in the response letter saying that we have exhausted appeal options. I don't know if I've heard of that. Unlimited.
I've heard of it. I personally would recommend moving to a different state. Other than one of confusion, at some point, a letter to the State Department of Insurance isn't unwarranted to ask them to intervene. Say you've made a good faith effort. After two back and forth, if you're still getting the same, reply that says we offer unlimited appeals and they're not going anywhere, that's where I start to head for the hills and look for outside sources. NCQA, State Department of Insurance, say we've made a good faith effort to resolve this. As you can see from the two attached letters, it either appears that the payer's not reading the letter or that they haven't further investigated based on what we provided in our appeal. Could you please intervene? That at a minimum will go to their compliance officer, and they may rattle some cages downstream to get you a reply. But I don't know of any other tricks to get out of that loop.
Okay, I'm going to answer. Actually, we're right at the top of the hour, so a lot of good questions. As I said, we'll do our best to get the Q&As posted within a couple of weeks on the website, or respond to you individually via email. So let's call that a wrap for today. Thank you, everyone. Don't forget to register for our October webinar, for the sepsis webinar tomorrow and next Wednesday, and we'll see you then. Thanks, everyone.
Thanks. Bye-bye.